Welcome to this episode of Guts and Glory. In this episode today, we are going to explore what really drives outcomes in GI and HPB surgery. And actually, we are going to move from the scalpel to the head end of the bed. Uh, it's not just technique, but teams which drive the outcome. I have with me Dr. Shishir Chandrasekhar. He is a leading anesthesiologist and as the head of anesthesia at Sakra World Hospital. He has a great pedigree and he's a multifaceted, talented personality. He spent more than a decade in UK training and working as consultant, and presently he's head of anesthesia at Sakra World Hospital, Bangalore. To me, one characteristic which describes Shishir is his unflappable demeanor in times of crisis. We know that complex surgeries need teams which are working in unison and having a good shared mental model. And today we'll unpack how surgeon and anesthetists, rather than working in parallel, work in teams and impact the outcome in long cases, patient with complex scenarios, comorbidities, frailty, and where the margin of error is simply very small. Welcome, Shishir, to this episode of Guts and Glory. And I'm going to pick your brains today in how we should be working across the table in the OR.
Thank you very much, Dr. Sikora. I'm delighted to be part of your channel. I must admit, I have watched several of your Guts and Glory podcasts with India's leading surgeons and eminent surgeons. And really, although the technical aspects sometimes have been beyond my pay grade, as it were, I have still taken away a lot of, how surgeons think, because it's another, like you said, an area we both common interest in. So I'm delighted that you have offered me the opportunity to come and share my views and look forward to a nice conversation.
So as I said, no, Shishir, that it's not only technique, but teams. And of course, we all realize that these are the two important teams in the OT.
Yeah.
But I want to hear from you that, you took up anesthesia and there was a traditional relationship between surgeon and anesthetist. I mean, you may highlight that, I may come up with that. But what do you think? Was it a good relationship? Has it evolved for the better? What would be an ideal interaction between a surgeon and anesthetist in the present era?
Yeah, I think traditionally, I agree with you. I think it was probably quite an asymmetric relationship in terms of importance and in terms of power, as it were. It started off, there is no denying, all anesthesiologists will agree that the surgeon was and continues to be the craftsman around whom the OT services and the surgery itself is underpinned, as it were. I think what started off was perhaps the idea was the surgeon was the craftsman. Everyone else just made sure that the surgeon could practice their craft well and safely. In anesthesia, if you go back to the couple of 100 years ago, perhaps was very nurse-led and very primitive in the sense. But it also is true, and all surgeons will agree, I'm sure, that it is anesthesia that has also made advances in surgery even possible. And again, if just I think back to even let alone hundreds of years, just in the 1950s, I think mortality due to anesthesia was probably as high as 1 in 4,000 to 1 in 2,000. And I think there was this important paper by Beecher et al. That is often quoted in anesthesia annals also, that came out that threw a spotlight on how critical the role of an anesthesiologist was in determining immediate postoperative outcomes. As a consequence of that, I think systems-led thinking, anesthesia was probably the first specialty to really embrace systems-based thinking. And if you just take back even in the last 40 years, which is probably, I mean, almost your years of practice, and I'm sure you will agree with this or have an opinion certainly. Even in the 80s, if you went to the US and had surgery in a good setup, your chances of dying under anesthesia was probably 1 in 5,000 to 1 in 10,000. And from that, over 30 years, we have seen a huge improvement in outcomes where now mortality directly attributable to anesthesia is probably less than 3 or 4 in a million in a good
Yes.
setup when it's done properly. So again, for those, some of us are aware of the concept of Six Sigma, which is a concept we have borrowed from manufacturing, where we look at the number of errors, and any manufacturing unit is said to have Six Sigma when the errors are less than 3 per million opportunities. And in
Mhm.
fact, anesthesia is probably approaching. We may not yet be Six Sigma, but we are getting there. We are probably in the region of 7 to 8 per million opportunities per million anesthetics is when we have a mortality ascribable to anesthesia. So that is where I think anesthesia has really grown as a specialty, and not just because of anesthesiologists, but obviously because of improvements in our understanding of physiology, better technology, better equipment. But a crucial part of it has been the understanding between a surgeon and an anesthetist, that we form essentially a dyad, as it were. The surgeon anesthetist combination has become really better understood. And I think that plus team training has made a huge difference.
Yeah, I mean, it's true that there is definitely a dramatic change in what the role of anesthetist and the impact of anesthesia in contributing to outcomes. But you know how it is in the operating theater. So let me ask you, who's the leader in the OT, according to you?
I think it's very situation specific. And to me, on a case to case basis, the way I kind of think of it is perhaps, I mean, just to give it, I'm a bit of an amateur musician myself. So the parallels I draw between surgery and anesthesia is that if surgery and the process of operation is an orchestra, I would still grant that the surgeon is the lead vocalist, but the anesthesiologist is probably the drummer or the tabla artist who keeps the beat. We keep the beat alive. so with kind of that way of that's how I think of it, and I think that is what much of medicine is. It's a complex science. It's an orchestra
Yeah,
more than linear and temporal events.
you
So
know, I feel like, you know, it's difficult to say, and as you said, to me, it's situational maybe
yeah,
that, if there is a crisis,
yes,
then there ought to be two leaders
yeah.
because
So if I could
surgical
just
team, which is doing the job which they have to do, and
yes.
the anesthesia. So it's not that somebody is directing, but everyone to need to know their job.
Rather than as a captain of a ship that a surgeon perhaps used to be, we are probably pilot and co-pilot of a flight, and there the
Right.
dynamics are quite different. And another thought I have is, see, based on it's like you said, situation specific. And as a broad rule of thumb, I think anything to do with anatomy or pathology, any situation leading up to that, the surgeon is definitely the person in charge of that situation. Anything to do with physiology and physiology related, perhaps an
Yeah,
anesthetist is in a
I
better
agree.
position to make a judgment because the surgeon is focusing deeply and there's tunneling of vision that happens as a consequence of that deep
Yeah,
focus. So together, if we are able, I think we will make a better decision in any situation as a dyad rather
yeah,
than doing that who's the boss sort of.
isolated.
Yeah.
Yeah. So let me put it like this, that in a high stake GI or HPB surgery, what kind of effective preoperative communication and collaboration you would like and do you have to ensure that it has a positive impact in the conduct of surgery and eventually the outcome? So what are the key elements in preoperative, discussions that you would undertake, would like to have, or are having with us. I mean, with we are working.
You, but even in my years of experience, couple of decades now, I have seen the transition happening from us being a purely operative specialty to more of a perioperative specialty. And I think one of the oft repeated things that we say is an anesthesiologist is a surgeon's physician and a physician's surgeon. So in
Yes.
answer to your question of a complex GI HPB case, which we have collaborated on now for a decade, and I consider it a privilege to have worked with you for this past decade. I think our process, our involvement starts well before the patient is wheeled into the OT. So if we take on as anesthesiologists more of a role in liaising between specialties, in risk stratification, risk optimization, I think we have already begun to play a role in that patient's outcome right from before the surgery.
Surgery.
I feel
But
our role is across the patient journey, perhaps not, certainly not as long as yours tends to be. Yours is a much more longitudinal relationship with the patient, but ours has traditionally been extremely cross-sectional, but we have tried to stretch that. And I think that has actually helped matters. What do you feel, Doctor?
let me be a little more, provocative.
Yeah.
Uh, It's absolutely true that we need more collaboration, we need more involvement. And as you said, who gives fitness? I mean, not a cardiologist who's sitting in the OPD, but the anesthetist should realize that is the physiology, cardiac physiology good enough? See, also in this era of specialization, not only in surgery, but in anesthesia also, now you have cardiac anesthetists, you have neuro anesthetists. Let me put it that is the time come now for having cohesive surgical teams which include anesthesia so that they could be longitudinally involved before in rehabilitation, in assessing fitness, in telling this, and be working with the same team all the time so that they are more on the same shared mental model. Has the time come for specialization in anesthesia?
Yeah, it's again a very tricky thing. Yes, I agree with you. I'm myself a pediatric anesthetist. I have worked, and as you know, our department is constituted of multiple It's probably better to call ourselves subspecialty anesthetists than super specialty, because what we are doing is we are still having good range of work that we can do, but then narrowing down to an area of interest. As a head of a department, I would like to think everybody can do everything, and everybody probably can, but the reality, and there is increasing evidence mounting. I think just last year in the JAMA there was a study on high risk cancer surgeries, GI surgeries, I think, where they looked at pancreatectomies and esophagectomies, and a third, I think, colorectal as well, and looked at the surgeon anesthetist diet, and those who had worked together. This was admittedly a retrospective study, I think, out of
Yeah.
Ontario, and I remember you sharing that with me. And one of the numbers that stuck in my mind is, for every year a surgeon and anesthetist have worked together, the mortality reduced by 5%. And those are
Yeah.
staggering numbers if they hold across, especially high risk specialties. And largely in India, I think it is beginning to happen. We are beginning to see that in terms of, with liver transplant programs, with pediatric
Yes.
programs, with cardiac
Yeah.
programs. And I think our outcomes are comparable to anywhere in the world. And a large part of that is because of the familiarity of the teams, rather than
Yeah.
seeing somebody strange at the head end every time you operate. So
So
I
can
think
I make a case for
now,
GI anesthetist to you?
I think, yes, I will have to agree. The evidence is mounting, and I think we have tried our best to kind of have a small pool. Right. But so you also need anesthetists who are generally versatile, who can handle anything that comes their way out of hours, or when the regular team that has been assembled is away for whatever reason. So I think it's a careful treading that has to happen.
So, I mean, continuing with that, no, Shishir, the thing is that now it's important to have trust in each other, to know that you have faith in the person standing at the head end, and vice versa. The anesthetist knows that this surgeon, these are the characteristics, and this is what to expect. In situations where you are not routinely working together or you are working as a big group, how do you, signal this kind of adjustment, trust, familiarity? How do you develop this in a group, if not in individuals?
Yeah, it's a great question. I think it's because the heat of the moment for the first time to interact with a new person is often very difficult. One of the things is I think these trusts are built over time. They're built in
Yes,
coffee rooms, they're built in the grand rounds of
yes.
hospitals, and that is when you understand each other. And the reality is that, we are all well trained in our specialty, but often don't see what the other person's thought processes are. So I think the more doctors mix with each other outside of a professional context, that also helps. What also helps, I feel, is protocolization as much as possible. Doctors generally, we hate guidelines and protocols, and we all think, we know we have a certain way which we have figured out which works well for us, and that may be the case. But especially in situations like these, as long as we are sticking to established standards of care, established guidelines, and that is what I think we have tried to do at places like our hospital also, where whoever, regardless of whoever is at the top end or at the surgical or at the operating end, there is not that much variation in what they ask for, the methodology, the thought processes. And I think that's been led by leaders like you who have uh,
No,
inculcated that consistency.
I agree with you what you're saying, but for me as a surgeon, if I have a person who is familiar, who has worked with me, who
Yes.
I trust, I don't have to bother about that side of the OT table. I know that this person is going to take care, and we just have to communicate when they are difficult. But when I have a person who's not familiar, I've not worked with, and not, I respond to every alarm. I respond every other hour to check whether the person is there or not there. So that kind of,
Yes.
burden is there for me personally.
Yes.
So that is why I bring
It's the
that
same thing. The
thing.
same thing is reciprocated. The same feeling is reciprocated from the top end as well. We much love working with people who have delivered in that kind of situation before. And when a new person comes, in fact, in many hospitals, there's a lot of churn happening lately. And when new people come, they come with new ideas. And it takes a good few cases for us to establish an equilibrium with them. So that same anxiety is also felt at the head end,
That's
but
what I mean.
communicated very yeah.
Absolutely.
Yeah.
And, sometimes you have that requirements.
Yes.
Uh, so typically that so many units of blood and all that, and suddenly you say, I mean, if you've worked with a surgeon, you know that what would be the blood loss. So those are the considerations which I am, but let's put that aside. We agree to the fact that perhaps it is time that we
Yes.
develop anesthesia teams akin to a surgical team, I mean, which works closely in a particular area. That may be the future. I think I would at least like it
No,
that way,
I
like
take
a
your point. And
cardiac
one
neuro
more
team.
point.
And
Sure. One more thing is, of course, that is not, it's a not a mutually exclusive thing. You can still be part of a nice larger department, but do this hyper focusing and
yeah.
suspect.
So if there is a crisis, uh, a surgical complication, what do you want the surgeon to communicate to you explicitly? You remember we had a bleed from the aorta.
Yes, yes.
Yeah. So, I mean, in such a crisis, how do you want a surgeon to communicate with you?
I think we recognize that it's incredibly stressful for the surgeon also at that particular time. Like now with a lot of laparoscopy, an attentive anesthetist also keeps an eye on what's happening in the surgical field. And many times we can pick up, like, that was an obvious, for example, the example you gave, where there was an obvious bleed from the aorta. It should not need us surgeon to tell us that that has happened. So an observant anesthetist firstly will pick up some stuff, but everything may not be picked up easily. I think transparency is extremely important in the communication. And in a way, whether it's an anesthetic complication or a surgical complication, establishing psychological safety within the team, I think really helps in the long run. Then we do not feel quite so judged. We feel that we are able to say what the problem is, like how a pilot would, for example. If there's a problem, they have these buzzwords that have to come out, not just using flowery language or a
Yeah.
wishy-washy language kind of thing.
Yeah.
So one of the things we, as I would suggest, and we try to do, is use a structured approach, something like the S bar, for example, makes it very clear that this is the S bar standing for situation, background, assessment, and recommendation. And this can be used across multiple scenarios. And this is one such thing. I'm sure that there may be other models, but that's the one I try to follow. I try to I would request the surgeon to let me know what the situation they are in, why that has happened. And if it's hyperacute, of course, we understand till the bleeding stops, there's nothing we can do. We have to help them do that. And if it means that, for instance, we have to do damage control anesthesia, if you can just tell us, you keep the pressures low for a little while so I can see my spurt, I pick it up quickly. We have the wherewithal to then understand why it is that you're asking. If I understand the context of what the surgeon is in, we are all on one team. Finally, it's all about the patient. In any kind of situation, if we try to imagine the situation from the patient's point of view, I think problems solve themselves. So what I expect is clarity and honesty, and what can be done about it, and what is modifiable from our side.
One of the most uh, difficult situations would be uncontrollable bleed from a major vessel, and that's where it's basically life-threatening. And I think we need to, from the surgeon's point of view, we need to communicate clearly. We need to designate people to do what they need to do in terms of that everyone is preoccupied with managing the patient, and somebody has to arrange blood, coordinate with the blood bank and things. And I think role allocation in this scenario may be a very critical thing.
Absolutely. And in this situation, especially in these kind of crisis resource managements, a senior anesthesiologist really earns his or her bucks at that time, because we
Yeah.
can't expect the senior surgeon who is hyper focused on that situation, trying to be able to think of everything.
Any instance you want to recollect or share with us where such a high crisis situation has been managed?
I think I was remembering the gentleman we did about a couple of months ago now, who was posted for an NET resection, and
Yeah.
you couldn't even get to the operating table by the time you were still coming into the OT when post anesthesia he went into profound hypotension, vasoplegia. He was peri-arrest for all practical
Yeah,
purposes.
I remember.
It might have been a
Yeah.
carcinoid crisis. We think he was very sensitive to the anesthetic drugs that we use. We are still not sure. And I think it becomes a diagnosis of exclusion. But this, I think, is where our teamwork really kicked in. Regardless of the cause of what happened, we knew what had to be done. And our team and your team, we liaised. Well, I shouldn't even say ours and yours, because we are one team finally.
Yeah.
We really worked in tandem. We worked sequentially, whereas we took, because it was a physiology related problem, I was at the head end trying to drive the drugs, drive CPR, things like that. You were offering not just moral support, but also trying to understand the big picture, getting, for instance, my cardiac anesthetist in quickly so that we could do a transesophageal echo to see what was going on, to speak to the family, to arrange for blood, should I arrange for an ICU bed, all of
Yeah.
that. And it happened so very nicely that I think a young anesthetist who was standing in the OT later, one of my postgraduates later told me she didn't even realize it was that bad, because everyone seemed to know their roles. Everyone seemed to have done
Yeah.
things so calmly. She thought it was just one of those hypotensions that had been handled well.
Yeah.
And, so I think the art of
Yeah.
making things look easy is often the hardest one. And that's just one example I can think of.
The other problem during surgery is unexpected or changed plans, and or a surgery which was scheduled to go for X number of hours gets prolonged. How do the anesthetists look at that, and how do you sort of, in that event, collaborate with the
Just
surgeons?
the way we need to look at it is, firstly, we are a team. We need to go through the whole process together. That would be definitely the ideal situation. Secondly, to reassess what your changed diagnosis or changed management strategy has on the physiology, on the homeostasis. It could be things, simple things like, would it necessitate blood, for instance? Would it necessitate closer hemodynamic monitoring? Would it change the plans as to where the patient would go? A potentially wardable patient might have to end up going to
Yeah.
HT. And these are decisions a good anesthesiologist at the head end will help the surgeon make by clarity of communication. And this is also where staying the course as an anesthetist really helps, because although a lot of what we do is protocolized, and there are two theories again within our fraternity also, that you should be in theory able to hand over a stable patient to the next person who should be able to run the same sort of anesthetic and get the same outcomes. And that is true probably in the ideal world, but often it is not the ideal world. And anesthesia, just like surgery, is both art and science. And we
Hmm.
also, over a period of a long hours on the table, get a feel for the patient. That feel is not transmissible to the person who we
Yes.
hand over to. And I think
Yes.
that's often, and when I see a surgeon, senior surgeon, staying back 8 hours, 10 hours, 12 hours till the end, I think hours should not be the issue here. We should finally think about it from the patient's perspective and be there
Yeah.
till we have stability.
The key, element which surfaces again and again is communication. And you know that at various levels of, your seniority, your experience, there is hesitancy to speak. So how do we, amongst your team and communication with the surgical team, how do you overcome these hierarchical barriers and also some, cultural barriers, so as to say?
I think a very true, very important point, especially in a cultural context like ours, which is essentially quite a hierarchical society. Again, I worked almost equal number of years in the West and here, and
Yeah.
one of the main differences I've always noticed is even a house officer there would feel quite confident and to articulate their opinion.
Hmm.
However informed it may or may not have been in the eyes of the seniors, but they had no worry trying to express, because I think that's more an individualistic society. They're more
Yeah.
confident as a people. Whereas in our system, we are much more deferential, and the deference has come even at senior levels between an anesthesiologist and a surgeon. While it's probably cultural legacy that we have had, it actually materially affects outcomes. So I think
Hmm.
here what we have to do is partly we have to introspect as seniors. Are we creating a culture where the right ideas, the best ideas win, and the best ideas are given importance rather than who the ideas are coming out from? But what we can do practically on a day-to-day basis is something we have trialed at Sakra successfully with GI, having the morning huddle, for example. So
Right.
the morning huddle, for those who may not be aware, is the senior surgeon, the senior anesthetist, senior nurse, anesthesia technician, all huddled together literally in the morning at about 8 o'clock before you start the list, go through each case, and each person articulates. So the like Dr. Sikora, you
What is
said,
the need?
shared mental model where you articulate what the case is going to be. I tell what things worries me about that patient. The nurse tells what equipment is needed. Technician may ask about blood. So this kind of thing creates a sense of teamwork. Firstly, for that
Yes.
day, that we are
Yes.
in this together. We'll get through this day together. And and over a period of time, it opens up that culture where people feel comfortable to talk. These are things that are done over time, I think.
Yeah. Because, sometimes I feel, I mean, from the opposite side or head end, that junior anesthetist does not want to uh, sort of share a concern of, say, a hemodynamic instability and not call the senior person simply because he or she might be found wanting in managing that situation, the impression it would create. So uh, I think they should be encouraged. If there's anything going off the, expected path, immediately inform the next person, manage how you want to, but keep the person in the loop and also inform the surgeon. I mean, that way
Okay.
it will open up their hesitancy to bring forth problems and not be uh, thinking that they would be judged whether they are being able to manage that or not. What do
Absolutely.
you think in your experience? There are differences which are, you know, unsurmountable between surgeons and anesthetists in terms of perspective?
Great question, because I have a strong opinion on this, and I think why it
Let's
happens
hear
is,
that.
yes.
I won't quote you in the OT.
No, why this happens is, I think the in within anesthesia, the asymmetry of risk and reward. If we understand that, you will understand anesthesiologists and anesthesia. Because the way I look at it is, as an anesthetist, what's the best reward I can get? I can leave the patient in the same way I found them in.
Hmm.
Whereas the risk is, unthinkable. It could be leading anything from small morbidity to serious morbidity to, fatal potentially outcomes. So we are almost hardwired to think along safety lines.
Hmm.
When, of course, surgeons also think about safety, but for surgeons, I feel as a specialty, it's more about doing, and that sense of curative thing comes in a lot more. So for you, the asymmetry is not so much. Your risks are high, undoubtedly they're high, but your rewards are also extremely high. So that is probably what drives surgeons to push the boundaries as much as possible, not out of ego, but the potential of providing that outcomes. And
Yeah.
this, I think, is where we fundamentally don't understand each other. For an anesthetist, the average anesthetist, the outcome is a safe patient at the end of the case. You
Yeah.
extubate them and you send them to PACU. For a surgeon, I think the outcome is when they can be discharged home. And in a socialized system, the real outcome is when they can go back to their job, start earning, and start paying back taxes. So
Yeah.
the real, I think this is where, if we are all on the same page and we understand, when you ask us to do certain things which we feel are probably testing the limits of physiology, when we understand that it's being done for the larger good, that, suppose a lap versus open, from what I have understood, laparoscopy is not any easier for the surgeon. Laparoscopy is harder for the surgeon, it's harder for the anesthetist from the physiology and everything, but better for the patient. And
Yeah.
we now accepted it, and robotic is now supplanting laparoscopy
Yeah.
because of exactly that reason. It might inconvenience us in that technically there'll be a learning curve. It may take longer to do. It's hard for us to keep homeostasis going for 8 hours, 10 hours sometimes. But if we understand we're doing it in the larger interest of the patient, and the
Yeah.
real outcome is discharge from hospital or getting back on their legs again,
Yeah.
that, I think, is when we really start thinking like a team.
I mean, smaller things like, fitness for surgery and need for blood and blood products. We often differ in the, I mean, how do you come to a common ground on that?
Again, it's only through dialogue. It's one is the body of work that we would have done together as a team over a period of time informs us. Now with you, I know, for example, I almost never ask for blood. I know a group and antibody screen is plenty good enough for the vast majority of patients. I can't really remember the last time I had to transfuse your patient, but I wish I could say the same for every surgery. It's not. So it's very context
Yeah.
specific. Risk also, again, exactly like I say, because we need to think about, although it might be great to do something less invasively or something more major or supra major, sometimes the better is the enemy of good, as they say.
Yeah.
So we sometimes have to accept that this
Perfection is the
best.
enemy of.
Yeah, perfection is the
Yeah.
enemy of competence, perhaps. So there, I think, only real thing I can think of is dialogue. As anesthetists, how we have to change is, again, if we think like perioperative physicians, we have a rapport with the patient from the pre-op, from well into the, from the prehab stage, and will continue to have that rapport post-operatively. That is, I think, when our mindsets will slowly change.
You should say, for example, you feel, I mean, if as a surgeon you feel that uh, Shishir is the best or most competent person, I have a difficult case, and I would like that person to be there. Is it unacceptable to
No,
put in
it's
a
not.
request?
No, no, no. Definitely not unacceptable. It's definitely a reasonable request to make. And I know when I refer patients to my surgeons, certain people I refer to and certain people I may not. So that kind of freedom we should have. And wherever possible, as an anesthesiologist, we should make every effort to honor that request as a head of a department. But that also has to be balanced in the context of, we have in our own hospital 15 operating rooms, varying degrees of sick patients, and that assessment as to who runs which list is also a difficult assessment to make as a head of a department.
A
So
difficult
wherever,
thing, actually, it's difficult thing to balance because
And each
everyone.
surgeon is viewing it understandably from their prism, for they want the best for their patient. But they imagine handling six such surgeons, and you may not have six anesthetists of same caliber available
Six
in.
Shishirs may not be there.
No, 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 no.
Well,
Sorry, not
we'll go for the
talking about.
pediatric one then.
No, no, not about myself.
Yeah,
But
we
yes, I
often
think,
miss you. Let's go to something more which is now being talked about in medical fraternity and medical circles is the impact of artificial intelligence. Uh, Now, we know in surgical specialty where all it has made an impact, which is bound to make an impact, and we will have to, get friendly with AI to be able to get its maximum benefit. In anesthesia, where do you see its role?
yeah, I think it's anesthesia as a specialty is really amenable to the implementation of AI. Firstly, we are quite technology heavy as a specialty, and we have become more and more so technologically reliant, more and more so. And if I really think about what my role is for the vast majority of a surgery, I'm a loop closer. As an anesthesiologist, I'm getting my feedback from multiple systems, multiple organ systems. They're telling me different things, and I'm, based on that, I'm tailoring my anesthetic up or down,
Yeah,
analgesia,
yeah,
relaxation, all of which can be potentially done by a machine with fewer distractions, no boredom, no fatigue. And so I feel that decision support systems have already started coming into anesthesia, and they will initially probably be advisory rather than to
yeah,
take over everything. But
yeah.
definitely it is helping us.
It could even tell you, with all the data which is there on that, it could tell you what kind of arrhythmia it is going on. It
Absolutely.
could tell you the respiratory insufficiency much ahead. It could preoperatively predict a high-risk patient
Yes,
with
risk
all the data
stratification.
fed in, isn't it?
Absolutely. Right
Yeah,
from risk stratification to intra-op to post-op, and getting our feedback like early warning scores that we use in
yeah,
the post-operative period. This could
yeah.
easily pick it up much quicker and relay it to us. So I think short answer is, will AI replace anesthetists? I
Of
don't think
course
so.
not, but
But an anesthetist who
it'll
uses
help them.
AI might replace an anesthetist who doesn't.
Let me ask you that, do you think the current relationship between anesthetists and surgeons is the best that we could have? Something which we can implement, say you recommend to be implemented at national level to improve the collaboration between anesthetists and surgeons for a good patient outcome.
I think the relationships are improving over at least last couple of decades. When we think about it, anesthetists are probably getting more of our due that we probably felt we were owed as seasoned and senior medical specialists. But again, the nature of our interactions is very, again, context specific. I think what could be one good equalizer would be minimum standards of monitoring and technology and equipment that should be made available across all sides. But purely at a personal level, I think we need to start thinking. My suggestion to my own team also is always that we and surgeons are not working at cross purposes. We are on the
Yes.
same team. And finally, the any doubt, if we keep our patient at the center of what we do, and rather than is the surgeon the boss or the anesthetist the boss, if we start accepting that the patient is the boss and
Yeah.
everybody works for the patient, a lot of these problems solve themselves. One of the
Yeah.
other suggestions I have is of thinking of ourselves as a dyad, thinking of ourselves, and perhaps if you add the OT nurse, head nurse, also as a
Yeah.
trio, basically. And if you
Yeah.
work as a trio, and if you also factor in intensive care as needed, which a lot of anesthetists also do, the more we think about providing end-to-end care for the patient as a team, I think we will find our work to be more meaningful, of more quality, and eventually result in better outcomes.
From my side, I personally feel it's lack of communication. Think we don't communicate directly.
Yes.
And that is the source of a lot of misunderstanding, miscommunication, and delays in taking decisions for patients. I think uh, we should be more forthcoming in direct interaction with each other rather than the third party or on just writing. So I think that would make a critical impact in improving how we understand each other. Because, you write something, but you don't understand the context. And the person who's reading doesn't understand the context in which it is being written. So if you talk, the context becomes clear and we understand each other, or either one of us can convince the other to their or the opposite viewpoint.
Right.
So I
And I think
think
both specialists we should spend more time with each other outside of the operating room
we
scenario.
should party also together.
Yes.
I must bring this at this stage, I must say by name that when Jayanti was the anesthetist with us, uh, I never looked at the head end
Mhm.
because I knew the patient from that point of view was in safe hands and I should be as safe as she is on this end. And she used to join our celebrations and farewells and welcomes as a member of the team. So I agree that you have to come and join us.
Absolutely. And I think I agree with you. Trust is binary. Either we trust someone or we don't. And it's all our jobs to make sure that we start working with each other to develop those levels of trust.
And it's so surprising, that something which we have to do together, we are interdependent on each other, but despite that, we still seem to have not cracked the code of a good uh, teamwork. Rather, it's just, as I said in the beginning, parallel work that I'm doing this part and you're doing that part, that kind of thing.
This
I
is
think we have
also,
to
I think,
overcome
where
that.
Dr. Sikora, things like joint audits will make a big difference, where
Yes,
we look at things in totality, clinical grand rounds, where we stop compartmentalizing grand rounds as a specialty specific grand rounds, but to think of it as a case based thing where everybody. We did that just a few weeks ago when your team's turn was, and I think those are sorts of things that really help break the ice and
yeah,
make us start thinking of all of us as one team. And these
yeah,
things, I think,
yeah.
really matter in the long run.
Thank you, Shishir. It was really great. But finally, I want you to give some message to trainees, anesthetists who are wanting to be anesthetists or who are in their early part of their career, and to surgeons, be it junior or senior surgeons. So, what message you have for three of these people?
I think for the young anesthetists, we should, it's a great branch. Often, people don't have much exposure as undergraduates to anesthesia. But anesthesia is a great branch. You have enough hands-on work that you can do, which makes a difference. Enough intellectual, thought processes and stuff that are needed to materially affect outcomes. It's a large, versatile branch. So I think we should firstly start wearing our badge of anesthetists with pride. It's happening already in India. And I think it's something that no branch is intrinsically superior or inferior to the other. We all play a role. And I think healthcare is a real puzzle, and that's the message I try to always think. Healthcare is not really complicated, it's actually complex, and there's a little difference between the two. Problems essentially are of three types. Simple, it's like baking a cake. You put the right ingredients, cake comes out the same way each time. Complicated is like putting a man on the moon, for example. It may look very difficult, but if you do all those steps sequentially, every time the man will land on the moon. Whereas complex is like, say raising two kids in the same household, and yet they turn out totally different. We understand that healthcare is complex, understand and embrace that complexity and work with each other as a team. I think we'll have fantastic outcomes and a very meaningful professional career, whether you choose surgery, anesthesia, internal medicine, it doesn't matter. As long as we
Yeah.
make difference to one small difference to one patient at a time, that is probably what we'll remember when we finish our shift, as it were.
I truly believe that it's a very critical uh, mm, cog in the wheel of what we do. And to me, it is important. And that is why I always make a effort to interact, find out, share, and discuss, because I feel that whatever progress surgery has made over the last decade or so would not have come about without the progress in anesthesia and anesthetic techniques. I understand that they are unsung heroes because, generally you don't get to be seen by the patient or appreciated the work which you do from the patient point of view, and all credit and also discredit goes to the surgeon. But I think the peers understand, or the fraternity or surgical fraternity, more often than not, understands that how critical the role they play. I personally believe that I think we need to have more interaction, more communication, and to get the best out of both the teams so that we benefit our patients as much as we can. But thank you very much for joining, sharing your thoughts, and I hope that we'll party more this year now, having agreed that that may be the
Amen to
best way
that.
to get
Yes.
together.
Thank you, Dr. Sikor. It was a delight talking to you and sharing, our thoughts. And I think we find a considerable degree of convergence in how we think about things. And hopefully, we will continue to have a long relationship professionally with each other and also get to party.
Now, before I close, Shishir, I know that you're a great singer. You enjoy that singing, and I would like you to sing a few notes on this podcast, please.
Oh gosh, what do I sing? Let's say, as just the first thought that came to me is this lovely song from Amar Prem, where we don't worry so much about what people think about us. Let us do our jobs properly, kind of thing. It's just the thought that came.
कुछ तो लोग कहेंगे.
Yes, absolutely. कुछ तो लोग कहेंगे, लोगों का काम है कहना, छोड़ो बेकार की बातों में कहीं बीत न जाए रहना, कुछ तो लोग कहेंगे. Thank you.
Thank you, thank you. That's appropriate. Let them say what they want. Just listen to the surgeons.